thank Dr. Seguin for inviting me. I'm honored to be among colleagues, but among colleagues that we don't communicate with. And that is what pretty much the subject of my presentation will be. And that is pregnancy and endometriosis, adenomyosis, maternal fetal risks. Dr. Seguin asked me to give this talk with the same title, but I added 3 words: the untold story. Disclosures. I am a consultant in a company that produces the Odon Assist device, which is an assisted vaginal birth device. It has nothing to do with what we are talking today. You all are familiar, I'm sure, with these SOG practice bulletins. Diagnosis of endometriosis this month, hot off the press, 17 pages. There is not one word about pregnancy. That's serious. Then I try to figure out what do the gynecologists or the malpractice bulletins say about adenomyosis. Actually, I couldn't find a practice bulletin on adenomyosis, just non-existing disease. I found it under diagnosis of abnormal uterine bleeding. What is going on? Gynecologists are doing gynecology, obstetricians are doing obstetrics, don't talk to each other. Well, that's our problems in obstetrics, you all know that. Preterm labor, preterm prom, preeclampsia, UGR, placental abruptio. These are called great obstetrical syndromes. Why? Because we have no etiology in obstetrics. We have been naive for years. We describe things as we see. Preterm labor, contractions, blah, 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 that they face, dilate the cervix. Preterm prom is when you break your water before labor. What is preeclampsia? Blood pressure plus protein. Whatever we see, nothing has to do with the etiology of this, right? Somehow think about this philosophically. How is it that a woman can have gynecological diseases, and when pregnancy starts, a new entity starts with a new diagnosis? We don't know what they are, but we give them names according to what we see, and we call them syndromes. Nevertheless, this great obstetrical syndromes in obstetrics is #1 cause for perinatal morbidity and mortality, along with congenital anomalies. Amazing to me that since 2015, there are 8 meta-analyses and 1 narrative review on endometriosis effects on pregnancy, 5 meta-analyses and 3 narrative reviews on adenomyosis in terms of the effects on pregnancy. That's not articles. That's narrative reviews over the last 10, 15 years. However, those are published in non-US and mostly non-obstetrical journals. You see the gap in the communication between obstetricians and gynecologists. I will summarize for you a summary pooled odds ratios, what all those meta-analyses come together to show. So connection with preterm birth, preterm prom, preeclampsia, SGA, aplasia, placenta, intrauterine fetal death. Everything with an asterisk is our great obstetrical syndromes. And you can see the odds ratios when this woman become pregnant in terms of endometriosis and adenomyosis. Anything that is yellow or orange, statistically significant. What do you notice right from the very beginning? That the risks, the obstetrical risks for women with endometriosis are increased. Moreover, those with adenomyosis, you start getting this. Adenomyosis is more of a risk than endometriosis if you put all together. However, the question #1 naturally will come in mind is, does the use of ART confound the adverse pregnancy outcomes in patients with endometriosis, adenomyosis? Is it the IVF procedure or is it just the disease per self? Well, here's the answer. There is a meta-analysis by Lalani, endometriosis, 33 studies from Canada, over 3 million patients actually, putting together the results, the associations in 3 groups of patients. Patients that with ART and endometriosis, patients who had endometriosis and conceived spontaneously, and then they analyzed the data with combined. What do you see here? Endometriosis risk for preterm labor, all three groups had increased risk for preterm birth as well as stillbirth. Placenta previa, if you see, the odds are creeping up again for placenta previa on all groups. Combined spontaneous conception and ART, also just spontaneous conception. You don't need ART to be at risk for pregnancy outcome in terms of placenta previa or cesarean delivery, of course. And all these complications, we get additional goodies here in addition to the obstetrical syndrome. Women with endometriosis are at increased risk. You can see the odds ratios. Preeclampsia, SGA, preterm prom, hemorrhage, gestational diabetes, cholestasis, malpresentation, dystocia, etc. And there is pathophysiology to explain all of those. Conclusion: both group of patients with endometriosis, either those who spontaneously conceive or via ART, they are at risk for adverse pregnancy outcomes. How about adenomyosis? Same thing. 17 studies in Irianakis. This is a meta-analysis that put together three groups: patients who conceive with ART only, natural conception, and a third group, ART plus natural conception. Again, preterm birth, preeclampsia, SGA, intrauterine fetal death, cesarean rate, postpartum hemorrhage, they are all increased. The conclusion, similar to the previous one, both patients with spontaneous conception and ART with adenomyosis are at elevated risk for abnormal pregnancy outcomes. Now there is another interesting one, meta-analysis where Busnell is trying, from Italy, try to untangle the independent effect of endometriosis and adenomyosis, and via systematic review meta-analysis. To me, I'm not sure I would have done it because obstetrically, to be honest with you, I start getting the feeling that this is the same disease, just in two different locations. So women with endometriosis alone, again, they're at increased risk for preterm birth, very preterm birth, cesarean rate, placenta previa, and you can see even the risk for placenta previa depends on the stage of endometriosis being greater at stages 3 and 4, as well as deep endometriosis. When they coexist, endometriosis with adenomyosis, you can see that the odds ratios are the highest. 4.6, 7.29, 6.51, 32.68 for placenta previa. What does that mean? The burden of the disease, the more it is, the more in trouble you are. Adenomyosis, poor adenomyosis, and I say poor for many reasons. We all thought that you cannot make a diagnosis of adenomyosis, but only in the hysterectomy specimen. That's an anathema teaching, which, of course, as you all know, it's not appropriate anymore because we have powerful imaging. But we are behind now. I think adenomyosis has been studied much less than endometriosis from your groups for obvious reasons. I don't think you can do too much for the lesions being in the uterine wall, whereas you can do a lot of things when it's outside, and you can write more papers for that. But obstetrically, adenomyosis appears to carry a greater risk. Why? I'm a simple man. I think it's because of the adjacency to the uterine cavity. So in this study, positive associations were again positive regardless of the methods of conception. Now this population-based study from Australia that showed again patients with endometriosis were at increased risk for preeclampsia, placenta previa, preterm birth. But the new information here we found out from this is that preterm birth increased risk is for spontaneous preterm birth as well as indicated, both of them. Why both? Via preeclampsia, UGR, etc. So again, that was independent of ART use. Is that real, really? Is that cause and effect here? The associations are real. I hope I convince you. I haven't seen a meta-analysis that's negative on the subject, either looking at adenomyosis or endometriosis. But is that cause and effect? Well, what could be the possible pathophysiologic mechanism for endometriosis or adenomyosis to cause trouble in pregnancy? Sterile inflammation, systematic disease. These two says everything. Dr. Hugh Taylor had a great slide there about systematic disease. I would think that perhaps he could add a pregnant uterus in there, because he had all the organs being attacked by those diseases, but pregnant uterus is also attacked. So now, few studies over the last 5-6 years, they have shown in patients with endometriosis, HMGB1, high mobility group B1 protein, is a great mediator of this inflammation in endometriosis as well as in adenomyosis. It appears that this molecule here, which you can see very high in ectopic endometrium and the expression of it, that it appears that in both situations, the excessive release of this molecule plays a critical role. Why do I say that? Because it links directly to obstetrics and premature labor. How? Look at this study. This study was done by Roberto Romero a few years ago, prior to the identification of the molecule that I described to you being having a major role in the pathogenesis. What you see here is people in preterm labor that he did amniocentesis. All his life he's trying to study the cause of preterm labor, and he's been after microbial associated amniotic infection. In this study, throughout the years, have been identifying that the biggest group is sterile inflammation. Now, in this study, there are 4 groups of patients based on amniocentesis results. This is a survival curve showing you the proportion of women that remain pregnant according to the amniocentesis results. The first group here has normal amniotic fluid analysis went longer. I want you to see the second group had this molecule HMGB1, which is increased in sterile inflammation, which is characterized as endometriosis and adenomyosis, that now is in the uterine cavity. And when you see that molecule in high concentrations, you can see the green line, these patients did as badly as the ones that they had microbial invasion. So you got that sterile inflammation in high quantities in your intrauterine cavity, you're doing as badly as if microbial invasion has occurred in terms of the outcome. And this is the same study there. You can see the blue represents the proportion of sterile inflammation in people going premature labor. Overall, for a woman who delivered prior to 37 weeks, you can see sterile inflammation 33%, microbial invasion 14%. Whoa. Now our thinking about the cause of preterm labor has to be reversing in terms of cause. For years, we were looking for this ascending infection that causes inflammation. But if indeed that was the inciting factor, that first the infection comes, and then the inflammation, it would be the group with microbial invasion much greater in proportion. So what appears to be is inflammation comes first, and infection comes second, makes sense teleogenetically. So in patients with endometriosis, adenomyosis, it appears cell injury that occur because of the sterile inflammation. We have the release of AMGB1, which is a molecule that's released in sterile inflammation. And if you are pregnant, and then there's binding on immune cell receptors in the chorioamnion, that results in premature rupture of the membranes. You have cytokines and other inflammatory mediators on top of this. You got preterm labor. You have the sterile inflammation that I show you, 33%. And then you have secondary microbial invasion. In other words, people with the sterile inflammation, it appears they are predisposed to microbial invasion. Is that a new concept? No, it's not. From all areas of medicine, we know if you're inflamed, you are at risk for microbial invasion. The same thing happens here. And there are other obstetrical conditions where sterile inflammation is much more prominent as compared to microbial invasion. This is amniocentesis results done in patients with preterm labor, second trimester miscarriages, cervical insufficiency, second trimester short cervix, idiopathic vaginal bleeding, and PROM. If you noticed, the proportion with sterile inflammation is always greater, which means in all these conditions coming first. Where it's coming from? I showed you the molecule. It's the same one that patients with endometriosis and adenomyosis produce in high amounts. Just another indication about the sterile inflammation, it's the first inciting factor, and that microbial invasion is secondary. Is these papers where antibiotic administration in patients with intraamniotic inflammation, in preterm labor and intact membranes, as well as patients with cervical insufficiency or idiopathic vaginal bleeding. All these patients have had amniocentesis, and sterile inflammation was proved via amniocentesis, and they did better as compared to no therapy with antibiotics. It makes no sense to give antibiotics and inflammation, you do better. Well, it does, because antibiotic treatment, it appears that basically prevents the secondary microbial invasion in these groups of patients. Diagnosis, I'm not going to say too much. You guys are better than I am, but I want you to show you this nice uterus, adenomyosis. Wow, look at that third uterus. Imagine implantation going to that uterus. I want you to see that uterus, the global interruptic junctional zone uterus, which is so inflamed. And I want you to compare it with the first uterus. Well, that uterus, my opinion, represents fetal environmental hazard. And I know that there is a lot of literature, coexistence, adenomyosis. As I said before, the best data, in my opinion, which I review, is that both conditions coexist in overwhelming majority of patients. As a matter of fact, obstetrically speaking, I don't see the difference. It depends where the disease is. And actually, I'm concerned more about adenomyosis, also with endometriosis. But to me, if you find one, based on what my understanding is, based on the latest study, the other coexists. Either you identify it or not. Take home messages. Of course, the great obstetrical syndromes I mentioned before, it seems to me, remember what I said in the beginning, they're all syndromes. Why not some of those patients with these obstetrical complications, preeclampsia, UGR, why not are patients with endometriosis and adenomyosis? I believe many of them are. In obstetrics, we have identified only IVF as a risk for abnormal pregnancy outcomes. However, this is something that we as obstetricians have to study prospectively. More important, we have to start looking about endometriosis, adenomyosis in the first trimester ultrasound screening. Most importantly, educate our patients. Even more importantly, as a colleagues, we got to speak to each other and kind of fill the gap, bridge the gap that has been created between gynecology and obstetrics. To summarize, endometriosis, adenomyosis, sterile inflammation that leads to obstetrical syndrome when the woman becomes pregnant. At the same time, it leads to impaired perfusion and placentation that leads to preeclampsia, UGR, abruptio, fetal death, and some other conditions, placenta previa, and other outcomes. My bottom line is, it appears to me at least, that these diseases do not cease to exist during pregnancy. Think about again, how come we have accepted that these gynecological diseases cease to exist during pregnancy? There's no other disease that ceases to exist during pregnancy, either medical or surgical. That is the only exception. I also want to finish by saying, in my opinion, based on the data I'm seeing here, endometriosis, adenomyosis are the nearest fetal environmental hazards. Thank you.